Good morning, and thank you for joining us today for our session exploring clinical dogma with the Depth of Anesthesia podcast team. My name is David Howe, and I'm a clinical fellow at Brigham and Women's Hospital.
And I'm Saddawi-Konefka. I'm an anesthesiologist and intensivist at the Mass General Hospital in Boston, where I also currently serve as the program director for the anesthesia residency.
I just want to start off by thanking the organizers of the IARS meeting for hosting our session today and for all the work behind the scenes to put together such a successful virtual conference. One thing we want to point out before we get started, we will have some interactive components near the beginning and at the end of the session. So if you're watching on your computer, have a mobile device nearby. You'll be using that to submit responses, and we'll have some more instructions on that later. We have no formal disclaimers to make or conflicts of interest. Dan, I just want to start off by asking you, why are we doing this session?
Yeah, so I think it really comes down to a shared belief that we have, and I suspect many of you share this belief as well. And that is that as academic anesthesiologists, we should always strive to be able to articulate both the logic and the evidence for the clinical decisions that we make every day. And if I'm honest with myself, and I suspect others will feel the same way, there are a lot of things that I do by habit, by dogma. It's been handed down from generation to generation. For example, maybe anytime you have a patient who's taking more than 20 milligrams of prednisone daily for 3 months, you give intraoperative stress dose steroids. And that may be right, but a lot of these habits, we end up treating them as truths without really getting critical about them and looking at the evidence. And as I've looked into some of my own habits, I found that some of them are, I'm happy to see, backed by high quality evidence, and some have no evidence, but they do follow from a principled approach to clinical care. I've also found that some of my habits are refuted by evidence, and in those cases, I need to reconsider them.
And I think that desire for deeper understanding is what drove us to create the Depth of Anesthesia podcast in the first place. And I think it aligns perfectly with the IARS mission, which is in part to disseminate basic and clinical research data in all areas of clinical anesthesia. I think overall, our hope is that anesthesiologists will become more critical of their practices, become dissatisfied with what they don't know, and start digging into the literature. So Dan, why don't you kick us off by just telling us a little bit about how this session is going to run today?
Well, I can tell you, David, I think it'll be fun for us. We're going to run it a little bit like we run the podcast episodes. So you'll notice, for example, that David and I will pass the mic back and forth. With regard to the outline of the session, first, we're going to have a short case vignette. Now, buried within that are going to be some practice habits, and we'll point one out in particular, and we'll talk about the implicit claims that that habit involves. We'll actually ask you about your level of agreement with that claim, and also what level of evidence you think exists to support your belief. The bulk of the session that follows will be a discussion of the relevant literature exploring that particular topic.
All right, so today we're going to consider a claim about airway management practices. And our case today is that of a 72-year-old man who's presenting for a laparoscopic umbilical hernia repair. He's 5'10" and 120 kilos, so BMI of about 38. And on examination, the patient has a thick neck, Mallampati class 2 airway, and class 2 upper lip bite test. Now, for the purposes of our discussion today, we're going to assume that the setting does not have access to sugammadex. We wanted to make sure that the scope of our literature review was manageable for the time we have today. So we do have one paper that examines sugammadex, and we'll give that a nod later on. So back to the case, the man is positioned in a 20-degree backup position and fully pre-oxygenated. And induction proceeds with 200 of propofol and 150 of fentanyl. Now, after the patient becomes apneic, mass ventilation is confirmed, and then 100 of rocuronium is given. Dan, what are some of the claims or habits you're seeing here in this case?
Yeah, so there are several potential practice habits we could talk about. We could look at the choice of propofol and fentanyl for induction agents. There's certainly lots of other choices we could have made. We could look at the doses that were selected. We could look at the use of backup position. The habits are really everywhere. The one that we picked for this session, though, is the confirmation of mask ventilation prior to the use of neuromuscular blockade. And certainly that's something that I was told when I was a trainee several times, that the safest approach was to check that you can ventilate before you administer the paralytic so you don't burn any bridges.
All right, Dan, so the stage is set. Let's find out what our audience thinks. This is going to be part of the interactive portion of the session, and we're going to be using a polling software called Mentimeter. So to access the poll, you're going to want to use your mobile phone, and we have two options here. You can either go to menti.com and enter the code shown, but I think it's probably easier if you use the camera on your mobile phone to scan this QR code. And the code will show a link that will then take you to the poll, and you can stay on that link for the rest of the questions.
It'll look something like that.
We're gonna give you a second to get that set up. All right, so here's the first question. Select your level of agreement with the following claim. In situations like the one described, mass ventilation should be confirmed before administration of neuromuscular blockade. So you're going to select your level of agreement, and then don't forget to hit submit. A lot of partially disagrees, partially agrees.
Leaves room for nuance.
Yeah. Okay. So the next question is, select the closest level of evidence that you think exists to support what you believe.
So I've made put my belief down, and now what's the evidence that I think exists for it?
Pretty spread out.
Yeah.
All right, so the next two questions are going to be free form. So you can enter short answers into the prompt. You can put in more than one answer if you'd like. So irrespective of whether you're on the check or don't check side, what are some reasons or rationales that could be given to check mass ventilation before neuromuscular blockade if the goal is to create the safest possible induction and intubation?
Two sort of similar answers. We'll be able to wake him up. We'll be able to emerge the patient. Understand the difficulty of the mask for the patient. May be able to wake them up prior to desaturation, depending on sufficient pre-oxygenation and short-acting drugs. Great.
So I'm seeing a lot of emerge the patient, wake them up, leave that there.
And a little bit of a little more information here about the patient.
Yep.
It's the way I've always done it. Avoid a cannot ventilate, cannot intubate situation, which I think probably dovetails with that way we can still wake them up.
Yeah. All right. Before we head to the next question, if you see something at the top that the presenter has changed the slide, you're going to want to click go to slide to get to the next question.
It would look like that. If you don't see that, you're already on the next question.
And so now we're going to ask, what are some reasons or rationales that could be given to not check mass ventilation prior to neuromuscular blockade? Again, if the goal is to create the safest possible induction and intubation.
Fear of aspiration, paralyzing will help me mask and intubate. Unlikely they can emerge. So that one's a little bit slightly different flavor. The idea that even if I don't give the neuromuscular blockade, they're not going to wake up. neuromuscular blockade will help me mask the patient.
Okay. So keep your phones out. Oh,
Oh,
a couple more.
Having the best condition and faster possible if I don't have time to emerge. So give sucks so I can proceed to intubating. Allows for easier masking conditions, avoids hypoxia and hypercarbia from inadequate masking. Get us going to a more definitive airway. Probably will desat before they emerge. I think that's the unlikely to emerge, very similar. It'll make the mask easier.
All right, so keep your phones out and we'll come back to the interactive portion at the end of this talk.
Okay. So I think what you all put in the polls are exactly some of the rationales that we've heard over time shopping this around with different folks, and I think they really do match what you put. So the rationale for checking first is really just to not burn that bridge, so that we can emerge the patient, but which wouldn't be possible if we've given neuromuscular blockade. That's the claim. Now that actually conflicts with this don't check rationale, which we've heard. And that is that emerging after typical induction, even if you don't give neuromuscular blockade, is not consistently realistic.
Right.
So we'll have to put those head to head and see what we can come up with. The other rationale for checking first is that it gives more data for future use for this patient. And I'll be honest, we don't have a lot of evidence to look at that. I think we'd want to look at evidence for, is that data useful in the future? What does it look like? We don't have a lot to talk about with regard to that. So that's just something to consider as you step through your own practice habits. And then the other rationale for not checking is that neuromuscular blockade will consistently help with mask ventilation or intubation, and delaying it is therefore less safe. So we'll explore these.
As we think about informing our practice with evidence, I think it's important to point out that the ideal study to answer this question just doesn't exist yet, and it may never. The outcomes that we care about, things like impossible mask ventilation, need for emergent surgical airway, need to emerge a patient, they're just very rare. So to adequately power a study, might need tens of thousands of patients who be randomized to check first or paralyze first. So I think instead what we have to do is use principles and some more upstream measures, and then cross-check these conclusions against some larger observational studies to try to piece this all together.
Yeah, I agree. And our goal today will not be to definitively answer the question. And one thing we'll ask, if you came in on the partially agree side, I want you to consider maybe the other side is right. If you came in on the partially disagree side, consider that maybe the other side is right. Considering the opposite is a really nice strategy for trying to unbias yourself and come to a more fair and balanced weighing of the evidence. All right, so with that, let's start digging into these subclaims. Now, the first one we're going to do is this head-to-head, can we actually emerge the patient? They look contradictory. Now here, the folks who want to check first might say that, well, if the mask is inadequate, they can wait for patients to spontaneously breathe. And the folks who say that they don't want to check first, they just want to paralyze, say that waiting for patients to breathe spontaneously is just not realistic. So if we were to graph what we're talking about, it might look something like this. At time 0, after pre-oxygenation, patients induced. If mask ventilation is impossible, patients eventually going to desaturate. And we're going to assume that there's just no mask ventilation at all. If we can mask ventilate, then it sort of becomes moot. We're really talking about the troublesome ones. Now, also at some point after induction, assuming the patient remains alive, the induction drugs will wear off enough that they'll start to breathe. So the question is, which comes first? Desaturation to the point of no return, or return of spontaneous respiration? To address this as it applies to our paralytic claim, we need to think about 3 questions. First, how long will it take for patients to desaturate to the point of no return? Second, how long will it take for spontaneous respiration to resume? And third, will additional administration of neuromuscular blockade burn the bridge to spontaneous respiration?
So Dan, let's start with the first question that needs to be answered. How long will it take for someone to desaturate to the point of no return? And we're going to talk about 2 studies to address this question. I think big picture studies like this, what they do is they induce patients and then see how long it takes for them to desaturate. Obviously, there's some ethical considerations here. So these patients don't actually desaturate to the point of no return. Instead, they desaturate to about 90%, which is the start of the steep part of the oxyhemoglobin desaturation curve. And so to answer our question beyond that, we have to do a little bit of extrapolation. So this first study was published by Gensi et al. In 1991, and they took 32 ASA 1 to 2 patients presenting for elective surgery under general anesthesia and divided them into 3 groups that are based on their BMI. The first group was the normal BMI group, so that's within 20% of ideal. Second group was the obese group, so they were more than 20% over ideal, but less than a cap of 45.5 over. And the third group was the morbidly obese group, who were more than 45.5 over ideal. All these patients were well pre-oxygenated, so end-tidal less than, nitrogen less than 5%, and this was all in the supine position. Now, here's a really important note. All the patients were manually ventilated once after induction. And if there was a concern at this point with how easy the masking was, this patient would be withdrawn from the study. Now, everybody else was allowed to then desaturate to 90%. So what did they find? Patients in the normal BMI group lasted about 7 minutes until they desaturated to 90%. Time to desaturation in the obese group was shorter at about 5 minutes, and in the morbidly obese group at about 3.5 minutes. We should note that these are average desaturation times, which means that some patients desaturate earlier. And you can see the standard deviations here on the table. A couple caveats I do want to point out. All patients got a safety breath check after induction, which would likely delay desaturation. So in reality, the time to desaturation would probably be a little shorter. And the study also excluded patients with any medical comorbidities, including pulmonary disease. So it's reasonable to assume that in patients who did have pulmonary disease, time to desaturation could also be a little bit shorter. And finally, all these patients were pre-oxygenated in the supine position. So a head-up position might have given us a little bit more time until desaturation with the increased FRC. So let's start dropping some of these data points on the graph that Dan showed us earlier. So again, we have oxygen saturation on the y-axis and time from induction on the x. And we can plot time to desaturation 90% for each of the groups. But again, the rest is going to be extrapolated. And you'll see that we decide to represent the standard deviations by the width of the curve. So there we go, our 3 groups from this article: normal BMI, obese, and morbidly obese. Dan, does this make sense?
I think so. What we care about is the point of no return, which is somewhere down here. We don't have that. What we have from the study are just these blue dots and the standard deviations when they're at 90%. So what we've done is taken typical desaturation curves and extrapolated some of the data from there. So normal BMI, maybe somewhere in the, I don't know, 6 to 10 minute range, all the way up to morbidly obese, that's maybe around 5 minutes. There were the caveats you gave about the safety check breath. And then there's other practice habits, as Dr. War put in the chat. Some people deliver oxygen to the back of the mouth during induction in obese patients. And if that's part of your practice habits, other studies might inform that maybe it goes a little bit longer. Do I have it right?
Yeah, that's exactly right. So Gensi is up on the graph, and let's add some more data points. Dan, I know you have another paper that looks at something very similar, right?
Right. So Gensi was all done in the supine position. And here's a very similar study. It was performed by Dixon and colleagues, published in Anesthesiology in 2005. There are a few important differences between the 2 studies. First, Dixon was performed only in morbidly obese patients. Second, they actually randomized patients to supine or 25-degree head of bed up positions. And third, pre-oxygenation wasn't actually as controlled as Gensi. So here in this study, they pre-oxygenated patients for 3 minutes of normal breathing at 100% FiO2, but there were no rigorous end-tidal oxygen concentration endpoints specified, so it may not have been as standardized. Induction was also performed with propofol, fentanyl, and succinylcholine, and it was followed by intubation. And intubation was another difference between this study and Gensi's. But similar to Gensi's study, they did perform a safety check breath, in this case to confirm that the endotracheal tube was in the correct position. And then they waited for these patients to desaturate to an SpO2 of 92%. So there were 21 patients in each group, and the supine group patients desaturated after about 2.5 minutes. Now, there was a spread, and it turns out that actually 6 of these patients desaturated within 90 seconds, within 1.5 minutes. The 21 patients in the 25-degree head of bed up position lasted an average of 3.5 minutes, although there was a spread here as well, with 1 patient desaturating within 1.5 minutes. Now, some of the caveats that are important for our purposes: there was a safety check breath, meaning that the patients might have actually desaturated a little bit faster had that not been in place. They did exclude patients with certain pulmonary disease. It's conceivable that those patients might desaturate faster as well. On the other hand, because they didn't track end-tidal oxygen concentrations, it's possible that pre-oxygenation could have improved or allowed for slightly longer times before desaturation, and other strategies weren't employed, things like oxygen in the back of the mouth, high flow nasal cannula. All of those might have increased the time before desaturation. Now, with those caveats, this paper actually aligns pretty well with Jensi's. So here's what Jensi's paper looked like, and we're going to compare it mostly to the morbidly obese arm because these patients were all morbidly obese. And when we overlay the two, here's the supine position, and here's the head of bed up position. Altogether, we have a spread of times for patients to desaturate, and that spread is pretty wide, even in patients of similar BMI. We haven't considered in this analysis supplemental oxygen during induction, and there may be other things that you do that would make you think that your data might look a little bit different. And if you have those, I'd encourage just more digging into the literature to see how it might apply.
Okay, so the next question we have is, if we want to wake them up, how long will it take for someone to have a return of spontaneous respiration? And to make this a consistently safe approach, we'll want to make sure that the distributions between the desaturation curves and the spontaneous respiration curves do not overlap. So we're going to touch on 3 studies to try to answer this question. Now, big picture, the way these studies are done is they induce patients with a specified induction regimen after fairly robust pre-oxygenation, and then they wait until they start to breathe again. So the first study we'll take a look at was published by Stefanuto in 2012. Now, what they did was they induced patients and recorded the time to return to spontaneous respiration. They also recorded whether anybody needed rescue interventions because of desaturation. So the study had 24 healthy adult volunteers who were well pre-oxygenated, minimum of 3 minutes or until the end expired oxygen is greater than 90. They were then induced with prop 2 mg per kg and either Remi 2 mics per or 1.5 per. Now, similar to Jensi and Dixon, a single small positive pressure breath was given a minute after induction, but then after that, the airway was left completely unsupported. Only if the SATs dropped below 80% did the practitioners then intervene with jaw thrust, positive pressure ventilation, things like that. So let's talk about the findings. So for the Remi 2 mics per group, the time from induction to spontaneous respiration was about 6 minutes. And for the Remi group, for the Remi 1.5 per group, the time was a bit shorter at 4.7 minutes. Now, across the entire study, the SATs dropped below 80% in a total of 5 volunteers, 4 of whom were in the Remi 2 mics per group, and only 1 of those actually required positive pressure ventilation. I just want to point out that this is an incredibly important outcome because here we have young and healthy patients who are desatting into the 80s with this induction regimen. This is after fairly robust pre-oxygenation. Now, I will say there are a couple of caveats like we've seen in the other articles. Again, we have a safety check breath. The population was young, healthy, so you might expect that older or sicker patients might be a bit more sensitive to the meds and take a little bit more time to start breathing. And these patients were also supine, and anybody with a BMI greater than 30 was excluded. So let's head to the graph. We have the results from the prior 2 studies, Jensi and Dixon, and let's go ahead and add the results from Stefanuto. So you can see our 2 groups here, the 2 mics per group at about 6 minutes and the 1.5 mic group at about 4.7 minutes for return to spontaneous respiration. Dan, what do you think?
Yeah, I'm thinking about something you said earlier, and that is that if we want emerging the patient to be a safe approach, we really need these curves to not overlap. Now, in this case, Stefanuto, these are young, healthy folks. We'd be comparing most appropriately to Jensi's normal BMI group over here. And if you look, the spread of this 2 mics per in the Remi group has pretty significant overlap. So to me, it's not that surprising that even though there were only 12 patients in this arm, 1 patient actually desaturated below a level of 80% and needed rescue positive pressure ventilation. So it strikes me that we either need to push these curves out further this way or move these curves in further this way to find a safe regimen. I want to talk about another study that also used prop 2 Remi 1.5 per. It's a pretty well done study. And it also will give us a little bit of a check. Is there anything special about Stefanuto? Maybe it shouldn't apply more broadly. So this study was done by Zhao and colleagues, and it was thoughtful in its design. It was a prospective randomized trial patients were randomized to two different induction regimens. Now, one of those included succinyl choline, and one of those did not. And we'll talk about the one that did not now, and we'll add the succinyl choline in just a little bit. So this non-paralyzed group were induced with propofol 2 per and Remi 1.5 per. That's exactly the same as the Stefanuto paper. These were similar patients as well. They were ASA 1 to 2. They were all women presenting for laparoscopic gynecologic cases. Now, 60 seconds after induction, the patients were actually intubated. So induction meds, then intubation, and then they waited. And they tapped the patients on the shoulders every 10 seconds and called their names. And as soon as the patients either started breathing or opened their eyes, the time was documented and the patients were re-induced.
Good study.
Yeah. So in the group that received 2 per of propofol and 1.5 per of remifentanil, apnea time, so the time until they started breathing again from induction, was right around 4 minutes with about a 1 minute standard deviation. Now, the same caveats exist as with Stefanuto's study, in that all of these are young and healthy patients. And it may be that other patients who are more sensitive to the apnea-inducing effects of these induction agents would have longer apnea times. So let's put it on the graph, and we'll see that it aligns really well with the Stefanuto paper. Here's the Stefanuto paper of 2 per with Remi 1.5 per. And if we add on top the Zhao paper, they do overlap. And that makes a lot of sense, given that the methods were fairly similar and the patient populations were similar as well.
All right, so our last study trying to answer the question of how long it'll take to breathe, again, here's a little bit different because this study was designed as a dose finding study rather than an apnea time study. This study was looking for the optimal induction regimen for smooth insertion of a cuffed oral pharyngeal airway versus LMAs. What this means for us is that the induction doses of propofol were variable because they were trying to find the optimal dose. So because of that, looking at standard deviations for apnea time won't be as meaningful, but looking at the mean induction doses and mean apnea times could still be helpful for our purposes. So the population was 75 ASA 1 to 2 patients presenting for elective surgery, and they all got varying doses of propofol and additionally randomized to either fentanyl at 1 mic per or saline. Now, the group that received just propofol got an average dose of about 2.5 to 3 mg per kg. Their average apnea time was just around 3 minutes. And the group that received fentanyl as well had an average propofol dose about 1.5. Their average apnea time was 2.6. All right, so back to the graph. You'll see that we've plotted the two groups studied in this paper without standard deviations. The fentanyl and propofol group at 2.6 minutes and the saline propofol group at 2.9.
That makes a lot of sense because it wasn't a standard dose of propofol, but rather different ranges. Including the standard deviations would probably overestimate the variance in this population. Now, we haven't in this graph shown other induction regimens, but I think it's worthwhile thinking about. There are some drugs that have less apnea induction. You might extrapolate out of that. You might find that there's other studies that help answer that question. You might find that there's not, and then do some studies to add to this literature. Let's talk about the third part of this, which is that neuromuscular blockade additionally might burn the bridge, might make it so that we can't come back to spontaneous respiration. So to kick that off, we'll go back to the Zhao paper. This is the one where patients were induced, intubated, and then tapped on the shoulder until they started breathing. I mentioned that there was a second arm to this paper, and that's where instead of Remi 1.5 per, they gave Remi 1 per with Sux 0.6 per. Otherwise, exactly the same. Now, in this case, times to spontaneous breathing were no different. And if you look at the graph, the curve, so here's Zhao, the original, we had the Sux arm, it almost completely overlays that. They lie right on top of each other. I think, David, we have one more study with paralytic and time to spontaneous respiration. Is that right?
Yeah, so this study is unique because it actually measures the time from induction to recovery of T1 to 10% and 90% of baseline. So what they did was they took 115 ASA 1 to 2 patients presenting for elective surgery and induced them with a non-standardized regimen, so opioids, propofol, other agents. And then the patients either got ROC and Sugamidex or Sux at 1 mg per. The Sugamidex was given specifically 3 minutes after the ROC, and then train of 4 was measured every 15 seconds to time the return of T1. So for the ROC and Sugamidex group, return to T1 of 10% was 4.4 minutes, and to 90% was 6.2. And in the sucks group, the return to T1 of 10% was 7.1 minutes and 90% was 10.9, so a bit longer. I do think it's important to observe that there's a fairly large standard deviation on the T1 at 90% in the sucks group. It's probably the largest standard deviation we've had so far. The other aspect of this is, Dan, I think in this study, using something like return of spontaneous respiration might not make a whole lot of sense because of the lack of standardization with the induction regimen. And I'm wondering if you have anything that might help us better understand or contextualize how T1 relates to what we're looking for.
Sure. So the idea here is that paralysis, when it gets in the way of spontaneous respiration, it's because the patient is still paralyzed. So we can't really look at time to apnea since they got a whole bunch of different propofol regimens, but we could look at how long it took for their strength to come back. Now, what does T1 at 10% mean versus 90? That's they take the baseline first twitch height, and then how long does it take to get back to 10% of those? And what does it mean as it relates to our purposes? Well, there was a study published in 2004 in ANA by Ella Orbany. We're not showing that here, but long story short, they did look at return to spontaneous respiration after succinylcholine and looked at T1 heights, varying percentages. And it turns out that at least in intubated patients that they looked at, return of breathing was most closely correlated with a T1 height of 10%. So this one right here. Mm-hmm. Now that was in intubated patients. In non-intubated patients, 10% may not be sufficient to keep the pharynx patent. So we've included the 90% here as well, because that's certainly more than adequate. So in non-intubated patients, the truth probably lies somewhere between these.
Mm-hmm. Great. So let's wrap up this graph with our final 4 data points. So first up are the sucks groups for return of T1 to 10% and 90%. And then we'll throw in the ROC and Sugammadex groups for return of T1 again to 10% and 90%. And Dan, I think that completes our graph. What do you think?
Yeah. So as I look at it, first thing I notice, there's a ton of overlap between the desaturation curves and these induction regimens. So to safely emerge patients, we either need to find strategies for longer times before desaturation or shorter times before return of spontaneous respiration. The other thing I'll mention is, at least for adding succinylcholine, that does seem to prolong the time at doses of 1 mg per kg, maybe not at the 0.6 per kg. Mm-hmm. So lots of stuff to think about there. So we've looked at if there's an impossible airway, can we emerge the patient claim? Now let's look at the claim that neuromuscular blockade improves mask ventilation. Now, David, there's some papers from the 80s and 90s that showed that the pharyngeal collapse was more common with neuromuscular blockade administration. And some people, based on that, voiced a reasonable concern that maybe neuromuscular blockade would then worsen mask ventilation because you have increased resistance to flow. On the other hand, some people said, well, gosh, patients are going to be not tolerating the mask, fighting me a little bit as I try to give them jaw thrust. And if I paralyze them, that goes away and maybe they're more compliant. Mm-hmm. So there's some rationale on each side. Now, it turns out that that's actually been studied directly, the impact on mask ventilation since in at least a few studies. You want to talk about the first one for us?
Yeah, so this is a very nice randomized controlled trial that really set out to look at the effect of neuromuscular blockade on the ease of mask ventilation. Now, what they did is they took 90 adult patients, pre-medicated them, and then induced them with a combination of lidocaine, fentanyl, and propofol, but no neuromuscular blockade off the bat. Now, 30 seconds after loss of the eyelash reflex, there was a baseline grading of the quality of mask ventilation by the Warder scale. I'll take a quick second to just chat about the scale. So this is a grading scale for mask ventilation. Now, the points in this scale stack. So if you're unable to ventilate, you get 4 points, but you also get an additional point if an oral or nasal airway is in use. Dan, does that make sense?
I think so. So if I think about someone who's troublesome to mask ventilate, maybe I put in an oral airway, maybe I need 2 people, and maybe even with that, I only get 2 to 5 cc's per kilo. So that person's score would be 1 + 2 + 2 or 5. Is that right?
Yeah. So, and in this study, a Warder scale of 3 or more was considered difficult. So back to the study, these patients were induced, and then you do the baseline blinded grading. And then they were given either ROC 0.6 mg per kg or saline. And then 2 minutes later, blinded grading happens again. Right. So what they found was that saline did not improve Warder's scores, but rocuronium did. Brock improved the scores from a mean of 2.3 to 1.2, and here a lower score signifies easier mask ventilation. Importantly, these results held in the subgroup with difficult mask ventilation, which was a baseline score of 3 or more. And in this group, the scores dropped from a mean of 4.2 to 1.9, or about 50%. A few caveats here that we should chat about. They excluded any patients who needed an awake fiber optic. We're not totally sure how many of those patients there were. And even though the practitioner was blinded, the ventilation part of this wasn't standardized. And there were multiple clinicians ultimately who ended up grading the mask ventilation. The big picture, there are relatively few difficult mask ventilations. Only 14 had a baseline Warder scale value of 3 or more. Dan, I know you have another paper that might help a bit with addressing some of the issues we're seeing here with the Warder's paper.
Yeah, it won't add a lot to the difficult mask ventilation because it didn't include a lot of difficult mask ventilation patients. But it does help a little bit with some of the standardization of the masking process. I do think it's interesting to point out that none of the patients here worsened after administration of rocuronium. Small numbers, though. So this other paper is done by Saddawi and colleagues. It was published in Anesthesia in 2014. They included 125 adult ASA 1 through 3 patients who were scheduled for GA with neuromuscular blockade. So what they did was this. They induced the patients, 15 degrees head up, propofol, fentanyl. After induction, patients were masked in a very, very scripted way. So they were put on the ventilator at pressure control at 15 centimeters of water at 12 breaths per minute. So that's now very standardized. And every patient got a 2-hand jaw thrust technique. Anesthesia was maintained with isoflurane through the mask until the end tidal anesthetic concentration reached 1 MAC. At that point, they waited 2 minutes measuring the tidal volumes, and the mean tidal volume was taken as the baseline score. So the idea here is if we standardize all aspects of ventilation, then the only thing that's really left is how difficult they are. So an easier mask would produce higher tidal volumes, and a more difficult mask would produce lower tidal volumes. After their baseline measures, they paralyzed, waited until the train of 4 was 0, and then took another 2 minutes of measures, and then took the average, the mean tidal volume there, and that was their post-paralytic measure. So what did they find? Well, they found that tidal volumes increased, but not by an earth-shattering amount, 525 cc's to 586 cc's. Now, importantly, none of them got worse, but that's not a whole lot. What do you think about that, David?
Dan, I have to be honest, I don't know how useful this data is because we're usually not worried about people who aren't difficult to mask, right?
Yeah, that's a really good point. Right here under the caveats, only 8 patients here were difficult to mask at baseline. So I don't know from this if we can really extrapolate to the difficult to mask patients. Now, in Warder's paper, it seemed that there was even bigger impact in the difficult to mask patients. So maybe if we had a study about that, we'd see that it was even more impactful. When I read this Saddawi paper, I thought to myself, oh, this might be a neat study to do. We could repeat this in difficult to mask ventilate patients. I got a little excited. And then I did a little bit more digging, and it turns out that the paper's actually already been done. The study's been done.
Very sorry.
So published by Soltesz and colleagues. It's a really nice study published in 2017 in Anesthesia. What they did was they basically repeated Saddawi's paper. It's 113 ASA 1 to 3 patients, but all of these patients had at least 3 risk factors for difficult mask ventilation. Here they are listed here, the risk factors they looked at. Now, all of these patients were induced in normal fashion, propofol, fentanyl, and then started on a remifentanil infusion. And after induction, they standardized masking. Now, remember, we're anticipating that these people might be difficult to mask. So the initial vent settings were pressure control 13/3, 12 breaths per minute. It was a single masker with over 20 years of experience. They put in an oral airway, the 2 hands, all of that was very standardized. They also had different pathways they could follow because they needed to keep the patient safe to increase the amount of pressure that was being delivered. So basically, after things settled, in other words, they found the settings that would deliver at least 2 cc's per kilo of tidal volume, then the ventilator settings were not changed at all for the rest of the study. They did 30 seconds, and they took the mean tidal volume as the average baseline. Then they paralyzed, waited until train of 4 was 0, and did another 30 seconds, looked at the mean tidal volumes to see what would happen with the train of 4 is 0. So what did they find? Well, first off, they found that these were difficult to mask patients. 55% of them could not be ventilated on these initial settings and achieve adequate tidal volumes. 24% of them had a Warder scale score of 4 or more. The other thing they found is that tidal volumes went up, and they went up by a significant amount. They increased from a median of 350 cc's to 600 cc's. And importantly, there were 0 cases with a decrease in tidal volumes. So that jives with both Warders and such data, where there were no decreases in tidal volume. Obviously, across these 3 studies, we're still not dealing with huge numbers, a total of maybe close to 300 patients. And there are some caveats as well. They did exclude some patients, anyone who was getting a planned awake fiber optic or anyone who was an aspiration risk. And the incidence of impossible mask ventilation, it's really low, only about 1 in 700. So they didn't have any. It's possible we're maybe not hitting all of the patients as we explore this.
Mm-hmm. All right, Dan, so that was a pretty robust review, I think, of some of the smaller studies that try to address the different components of the claim, like how long does it take to desaturate, how long does it take to breathe, and what's the effect of neuromuscular blockade on mass ventilation. But all of these upstream questions are still a couple steps removed from the big question we have. So I think they can help inform our practice, but it'd be helpful to look at some of the larger observational studies to see how things actually stack up. Of course, these studies won't have comparator groups where we can ascribe causality, but I think it could still be informative. So let's talk about 2 large observational studies that are like that.
Absolutely. So this first study is by Ketterpaul and colleagues from the University of Michigan. It was published in Anesthesiology in 2009. They looked at 4 years of data. They included any general anesthetics that included a mask ventilation attempt, which turned out to be over 50,000 patients. And then they looked at the incidence of impossible mask ventilation, and they looked at the outcomes, the drugs used, those sort of things for those 77. And those are reported as a group. So of these 53,000 patients, there were 77 impossible mask ventilations, 0.15%, or about 1 out of 689. So what happened with them? Well, it turns out 58 of them, the majority, were intubated normally. Now, the other 19 were more difficult. 15 of those were intubated with alternative intubation techniques, and there were 4 who had a slightly different path. 3 of them were emerged. 1 received an emergent surgical airway. Now, unfortunately, from what's published in the paper, we don't know a lot about the individuals within the 77. We know that 73 of the 77 received neuromuscular blockade, so only 4 did not. But we don't know which 73 received them. We don't know the timing of the receipt of them. We don't know the timing of it as compared with documentation of impossible mask ventilation and so forth. If I were to guess, I might guess that the folks who were intubated were more likely to receive paralytic, because that's often goes together. But this is a very small group of patients out of 50,000. So maybe there's something else strange going on, and that's not the case. Mm-hmm. 3 were also woken up, which I think is very interesting that escape route was taken. I don't know if that was the intended thing from the start. Importantly, also, one of these was not emerged and received instead an emergent surgical airway. Some of the caveats for this paper: it relies on clinician self-report as it's an observational trial. It's only a single institution. So the practice patterns there may be not generalizable. Maybe they do a lot more awake fiber optics, maybe they do many fewer, and so forth. The other is that though the majority of patients received neuromuscular blockade, we don't know all the details around how those stacked up and how those informed these outcomes. David, I think we have one more study that's large and observational. Is that right?
Yeah, so this was a study that did not set out to answer the question of whether to paralyze early or late, but instead it was a prospective study designed to validate a new difficult airway algorithm. So the study enrolled 12,000 patients presenting for elective surgery under general anesthesia and requiring tracheal intubation. Now, big picture, for any induction that was at risk for a difficult or even potentially difficult airway, the patient got succinylcholine a mg per immediately. So in essence, these folks were definitely in the non-checkers camp. And I think this study could be kind of taken as a prospective assessment of the safety of that approach. Right off the bat, they examined each patient for risk factors for difficult intubation. And if they had 3 or more, they were deemed high risk and sucks was given immediately on induction. Now, everyone else was then induced without succinylcholine, and then mask ventilation was graded. But if the mass ventilation was challenging, sucks was given. And then the difficulty of mass ventilation was graded again. Dan, I just want to pause there for a quick second and make sure the overall process and the workflow for this study makes sense to you.
Yeah, I think so. So they seem strongly in the non-checker camp. We saw how long it took to get T1 height back after 1 milligram per kilo of succinylcholine. So it seems like they were thinking, at least their process was, we're going to put them down. We're going to put them down hard with paralytic and just do our best to take care of the airway. Is that right?
Yeah, that's exactly right. So let's chat about what they found. So 4 patients were excluded and intubated by nasal fiber optic. And then of the remaining 11,982 were intubated with a Mac Blake successfully. 236 were intubated with alternative techniques, things like bougie, video laryngoscopy. But importantly, there were no mortalities or aspirations. Hypoxemia, where SATs dropped less than 90, was seen in 87 patients, so 0.7%. And SATs dropped to less than 80 in 17 patients, so only 0.1%. Now, the lowest SAT was 68%, and this was in a patient where mass ventilation was not possible. Gentleman had a bushy beard, 5 predictors of a difficult airway. And a final other aspect of this paper, which I think dovetails nicely with our prior discussion, is that sucks never worsened face mask ventilation quality. Of the 90 who received sucks after initial challenging mass ventilation, 56 of them improved by 1 grade on a 4-grade scale for mass ventilation.
David, 2 quick questions on this. One, it looks like 4 patients, based on their predetermined criteria, were diverted to receiving awake fiber optics. So I'm curious, who are these patients? What's special about them that they were not included? And the other question I'm curious about is, for the gentleman you said that desatted to 68, what actually happened with them?
Yeah, so 4 patients were excluded off the bat. 1 had a prior history of difficult intubation. 1 had a large thyroid tumor distorting the airway, and 2 had fixed cervical flexion deformities with limited mouth opening. So those 4 went off to wake fiber optics. And the bushy beard gentleman, he did fine. He was rescued with an LMA. But an interesting side point here, after the group's experience with this patient, they actually decided that for all future morbidly obese patients with a beard, they'd be required to shave it before surgery.
Interesting.
Some important caveats. This was a study conducted by experienced practitioners, so 15 anesthesiologists, all with more than 5 years of clinical experience. And this was a single center study at a surgical teaching hospital in France. So Dan, we've gone through and tackled some of the principles and upstream measures and corroborated those with some of the larger observational studies to try to better understand the evidence behind some of the rationales related to the claim for our case today. Let's take a look back and summarize some of the findings.
Sure thing. So first, we looked at the question of whether or not you can safely emerge a patient after induction before they hit the point of no return. And we saw some wide standard deviations and a few different induction regimens. We also looked at the effect of neuromuscular blockade on mask ventilation. Now, these all showed that mask ventilation was improved with neuromuscular blockade, and no patients across the 3 studies worsened. That said, these were all relatively small, a total of only about 300 patients. So based on these principles, we then turned to observational studies. We looked at Caterpillars, which was a retrospective study, and we saw that within that, the incidence of impossible mask ventilation was small. Most of those patients could be safely managed with a secure airway, but there were 3 that were emerged of the 50,000, and 1 who was not emerged and instead went to an emergent surgical airway. Lastly, we looked at Mathieu, which shows a prospective validation in essence of the paralyzed first approach. At least in the hands of these investigators, it proved to be fairly safe. There's a QR code here that you can use. You can also go to https, don't forget the S, /bit.ly/DOA-IRS, that's death of anesthesia-IRS, to get links to all of our papers that we're referencing here.
So Dan, let's head back to the 2 questions we asked at the start of the show. And this is our case again, the 72-year-old gentleman for laparoscopic umbilical hernia repair. The claim again being, in situations like the one described, mass ventilation should be confirmed before administering neuromuscular blockade. And so we're going to ask you to take your mobile devices out again. And if you're still on the link, you can either refresh that or head to menti.com using the code 52214503. And select your level of agreement with the following claim. In situations like the one described, mass ventilation should be confirmed before administration of neuromuscular blockade. Whoa.
That's a lot less of a spread. Ah,
Okay.
excellent. Okay.
And we'll head to the next question. Select the closest level of evidence that you think exists to support what you believe. A little bit of a shift to.
Yeah. I'm happy to see that, some more familiarity with the evidence.
That's right.
I think that's our goal. Just while these answers are coming in, Dr. Warren in the chat says, we need more deep dives into our clinical dogma. Much of what we accept as evidence-based practice, best practice, when it's nothing of the sort. We completely agree. That's sort of the mission that I think many of us hold, and it's certainly what prompted us to make the Depth of Anesthesia podcast in the first place.
A tremendous thank you to all the people who have supported us along the way. We especially want to acknowledge Dr. Shayun Johnson-Akeju, who's the chair of anesthesia at MGH, for his unwavering support. I also want to thank Dr. Keith Baker and Dr. Dan Leisman for helping us review this presentation. There are also many other people, including Dr. Alyssa Walsh, who have made the podcast what it is today. And for that, we're immensely grateful. And thank you to the IARS for making this conference and this session a reality.
Thank you all so much. We'll certainly be open for questions. I'll add also a plug that if you are interested in this sort of thing and you have any clinical dogma that you'd like to see explored on the podcast, or if maybe you've done the exploration of some clinical dogma and would like to be on the podcast, to just reach out. We'll hang out for questions and comments and discussion. Thank you all. Thank you, Dr. Walsh. Thank you, Dr. Janda. Thank you very much, Dr. I'll go with Gelco Garcia. Apologies for mispronunciations. Thank you for the comment. Dr. Baker.
Yeah, good morning. I was wondering, since I was raised in the era where one would check before administering neuromuscular blockade agents, and then that transitioned to more recent evidence-based findings that actually things get better with neuromuscular blockade. I wonder how much of that occurred because of our increase in both training and availability of what I call gizmos to solve airway problems. For example, when I started training, there weren't some of the nice glide scopes of today. Fiber optic bronchoscopes were infrequently found, or being repaired or something. And nowadays, every room seems to have a glide scope readily available, bronchoscopes abound, and so on. And so the confidence that people have and the skill perhaps in training has improved to the point where some of what used to be probably actually dangerous is no longer that way. So how much of what you find do you think might be an evolution in techniques and technology?
I think that's a really good point. I mean, if you look at the large observational studies that we looked at, which were Ketterpal and Mathieu, in the impossible mask ventilation folks in Ketterpal, though the majority of the 77 were intubated conventionally, there were 15 who got sort of, I'll call them trick shots to get the airway in. And those gizmos that you talked about may not have been available prior. And similarly with Mathieu, you know, they actually had a very prescribed, this is how we're going to intubate them, which included using devices that didn't exist before, things like the air track, things like an intubating LMA and so forth. So I think it's very reasonable to assume that maybe Dogma that held or was more rational in certain settings maybe aren't as useful when those resources are available. Just as importantly, even today, if you're in a setting that doesn't have those resources available, you might need to adjust accordingly. I'm curious, Dr. Baker, from your training, you know, how often were patients emerged after they couldn't be masked when you didn't have the gizmos? And for those that were emerged, what were the induction cocktails that were used?
So it's going back a long time, and you know, I didn't have access to what everyone was doing, but I do know that a number of patients were emerged. There would be some struggling to get them intubated. It would fail. They would then wake them up. There would be enough oxygenation to keep the harm at bay, and then they'd be intubated awake with a bronchoscope or a blind nasal or whatever technique was available at that time. So, but it definitely happened. And I know for sure that the use of fiber optic bronchoscopy was definitely still being mastered. And I can recall being told not to use it. It was not standard of care and not to practice because it was only for special difficult problems. So I know that the thinking on the use of the bronchoscope has changed over the last many years. And then again, that the glide scope can, you know, see around corners, so to speak. So I do think that the dogma of yesteryear may not have been as evidence poor. It was sort of experientially based, and horror stories did exist to back up some of behaviors that were happening. And nowadays, it's unusual to have a truly unsolvable airway problem. They do exist, but their frequency is quite low. We just don't hear that many of them.
Mm-hmm. I think that's well said. Were there horror stories on the other side? The attempted emergence that ended up not working out?
Not that I know of. No. I mean, I know of I do recall a case that there was injury, but that was a surgical mishap of a lost airway. So those sorts of things are unsolvable. You can be in the airway and your problem is still not solved. So I think that's a completely different class of problems. It was kind of the 1983 paper by Cormack and Lehane that gave us the grading scale for laryngoscopy. Actually put bronchoscopic examination or bronchoscopic intubation in the this is not to be used. This is for specialists only. Don't think of that as a normal way to solve your airway problems, because at that time it was really considered a trick shot, to use your term, and not standard, not taught to everyone. Whereas nowadays, all trainees learn to use the bronchoscope to intubate people. They use them on the mannequins, they practice in patients. I mean, they're quite facile with these technologies. And so I think things have changed.
Yeah. Thank you for the comments. As I'm listening to you, I'm thinking it would be really neat. I don't know if the literature exists, but if not, to see if we could get our hands on anesthetic records from, you know, the 70s and 80s and just find the subset of folks who were emerged to sort of catalog like what were the inductions like.
I do know there were some episodes of hour-long intubations I do know that. I mean, that's a long time to spend flogging the airway, as we say.
Yeah.
But people,
Well, so
people
that's
did.
interesting. I'd have to imagine, unless we've adopted some seal physiology, that there must have been some ventilation happening along the way.
Yep, that's right.
Yeah.
Some, enough.
Enough, just enough. Well, thank you all so much. I think we've reached the end of our hour. I hope you all continue to enjoy the IARS meeting. I know we will.